Well, I think with this audience, I don't even need to say hello. I know you've just come home to the house, as you often do, but may I, as I usually do, honour our traditional owners, the custodians of this land around here, Gadigal, in their language, Bujuri Gamarua, Dian Babana Gamarada. We did have a brief conversation about the demographic for tonight's lecture, but of course there is a saying that the definition of middle age is anyone 10 years older than yourself. So I think we're all very well, very middle-aged in this particular audience. I also have to say that I must apologise for Dennis's absence tonight. I think I would define it as a studied absence. We've had a conversation, in fact several conversations, around the particular topic of hearing, which he doesn't seem to, I'm not sure whether he doesn't hear or whether he doesn't listen to, but there you go. But anyway, he decided that the traffic was very heavy and he hadn't quite made it, but I'm sure that we're going to be able to present some material to him. But may I say, my introduction to this world of hearing loss and its significance really came through Brendan Lonergan, who is here with us tonight, and he's President of Hearing Matters Australia. I had met Brendan some years ago. He was the CEO of another patronage organisation, and I very much admired the way he did his work there. He then moved to Hearing Matters Australia, and he approached me for patronage of that, for which I felt very honoured, and I was particularly honoured to receive his invitation to speak at the World Hearing Day celebrations at Macquarie University in March this year. And as I found out then, and I continue to find out, there was much to hear and much to learn on that particular occasion. And it was nearly 20 years ago that Access Economics released their landmark Listen Here report into the economic cost of hearing loss in Australia. That had been commissioned by CRC Hear and the Victorian Deaf Society, and the report used modelling and reported data to estimate that at that time around 3.6 million Australians, about 1 in 6, were affected by hearing loss, and that's a bit of a startling figure when you think about it. We only have to sort of count each row and we know where we're at. That report and all subsequent attempts to enumerate the prevalence of hearing loss in Australia, and most of which drew on those 2006 findings, included a clear caveat that they were likely to be conservative estimates. Moreover, citing Australia's ageing population, that 2006 report expected that the 1 in 6 prevalence would rise to 1 in 4 by 2050, which seems to be that magic period in our history that everything seems to be directed to these days. But as a recent article on the Better Hearing Australia website points out, applying such a progression would imply that we would have reached a 1 in 5 prevalence last year. Alarmingly, the 2006 report also found that although most hearing loss can be attributed to ageing, one third of Australians who suffer hearing loss do so through preventable causes. The increased use of listening devices and associated unsafe listening habits is likely to swell this proportion. Indeed, a 2011 study estimated that 17% of US teenagers already had signs of noise-induced hearing loss, and it wouldn't be different here, one would expect. More contemporary data is thus really needed, not only to gauge the true extent of hearing loss in Australia, but also to calibrate public health responses to it. Acquiring such data, however, is notoriously complex, as I'm sure we're going to hear about tonight. Self-reporting is hampered by stigma, denial, or even a lack of awareness, and people often avoid formal testing, particularly if their hearing loss is mild, gradual, or dismissed as a normal part of ageing. Such attitudes also flow into the uptake of technologies that might assist those with hearing loss. 4 in 5 Australians who would benefit from using a hearing aid apparently don't use a hearing aid. The impact of hearing loss, no matter its degree, is dramatic. It's also usually irreversible and is often progressive. To paraphrase Helen Keller, losing your sight cuts you off from things. Losing your hearing cuts you off from people. Undiagnosed, untreated or unsupported, hearing loss tends to lead to social isolation, frustration and a loss of confidence. And the consequence ripples outwards, affecting mental health, employability and, importantly, even accelerating cognitive decline. I think that's the one that got me that really captured me when I heard that. Hence, this is not just a health issue, albeit often unrecognised, but a matter of human rights, an issue deserving of our fullest attention and action. Encouragingly, there is a growing momentum to tackle these challenges, not only through advances and incredible advances in hearing technology, but also through adopting people-centred approaches that put dignity, equity and accessibility at the heart of care. So it's particularly inspiring to see the strong collaboration among researchers, clinicians, service providers, consumer advocates and community organisations, and that was very much what that symposium was about in March of this year. Such partnerships both advance the science and understanding of hearing loss, as well as transforming and shaping the systems and policies through which people with hearing loss might be supported and empowered, leading to immeasurable improvement in their lives. And there is absolutely no better person to guide us through the complex intersections of hearing loss, public health responses, and the current research state of play than tonight's presenter at this, the 14th iteration of Ideas at the House. As inaugural Cochlear Chair in Hearing and Health at Macquarie University, tonight's presenter leads the university's public health and policy pillar. I'll get to her name, I really will. I want to keep you in suspense. She has co-authored over 275 peer-reviewed based evidence on the health, determinants and outcomes associated with sensory loss and disability. She's also co-lead of the Australian Eye and Ear Health Survey, some results of which I understand she's going to share with us tonight. So, to the wonderful, the wonderful scientist, researcher who leads us in such a significant area of health and public health, may I welcome Professor Bamini Gopinath to the stage to give her presentation, Busting Myths, Bridging Gaps, Public Health Approaches to Hearing Loss in Adults. Professor Gopinath, welcome.
Good evening, distinguished guests. It's a real pleasure to be here. Thank you, Your Excellency, for such a comprehensive overview on hearing loss. I'd also like to thank Professor Slade for the very kind invitation to speak at this event tonight. Very grateful for the opportunity. I'd like to acknowledge the traditional custodians, the Gadigal people, and pay my respects to elders past, present, and emerging. So my presentation today is on busting myths and bridging gaps when it comes to hearing loss in adults, and also to highlight some of the public health approaches that are out there in terms of targeting adult-onset hearing loss. Now, there are a lot of misconceptions around hearing loss in adults, but the good news is that there is high-quality research that is emerging globally and locally, including research that's done by our group at Macquarie University Hearing that aims to dispel some of these myths or misconceptions. And that's really what I want to highlight today. But before I get into this, I want to give you a very high-level overview of hearing loss, including its prevalence and burden. So in terms of the types of hearing loss, the most common type of hearing loss is sensory neural hearing loss. And this is permanent hearing loss, and this is caused by damage that's been done to the tiny hair-like cells in your inner ear, or damage that's been done to the auditory nerve. And what this does is it prevents or weakens the transfer of nerve signals to the brain. As a result, information around the loudness and clarity of sounds is lost. And when sensory neural hearing loss occurs in children, it's most likely due to a genetic syndrome or due to an infection that's been passed down from the mother to the fetus inside the womb. So it's infections such as rubella or herpes. If sensory neural hearing loss occurs later in life, this is due to a wide variety of triggers. So of course the aging process is the most prominent trigger, but there are other causes like noise-related damage or drug side effects. So in the presentation today, I'm going to be focusing on sensory neural hearing loss, which is the most prevalent type of hearing condition, and it's a focus area for our group. But of course there's also conductive hearing loss, and this is temporary hearing loss, and it can be treated if it's due to causes such as ear wax buildup or fluid in the middle ear or ear infections. But it can end up being permanent if there's been structural damage that occurs or if there's an ongoing or chronic ear condition. So a hearing test can often tell you what sort of hearing loss you might have, and as a result, appropriate interventions can then be implemented. So I want to move on to some global data, and I've taken this directly from the WHO World Report on Hearing, which was published back in 2021. So the WHO estimates that currently over 1.5 billion people are affected by hearing loss. 80% of these individuals live in low and middle income countries. Hearing loss is very much on the rise. So the report estimates that by the year 2050, around 2.5 billion people will have some form of hearing loss. So there is this urgent need for countries to act now and make hearing loss a public health priority. There is a high cost to inaction. So unaddressed or untreated hearing loss costs over 980 billion annually, and over 50% of these costs are attributed to low and middle income countries. So targeting hearing loss is actually cost effective. So for every dollar that's spent in addressing hearing loss, you get back a return of $16. So when we talk about addressing or targeting hearing loss, effective intervention starts with systematic screening of certain subpopulations. So Australia are global leaders when it comes to universal newborn hearing screening programs. However, we don't do screening of other subpopulations as well, and particularly screening of hearing loss in older adults doesn't happen. It's not routine, and this is a critical gap. I also want to highlight some local data. So this is hot off the press data from the Australian Eye and Ear Health Survey. This is the first national survey of its kind, and it's a collaboration between Macquarie University, University of Sydney, UNSW, and several other institutes. It was funded through the Department of Health and through philanthropic donations. So we just wrapped up data collection earlier this year, and so we're still in the process of analysing and writing up the key findings. So I'm only going to present some very initial analysis today. So our participants were recruited from 30 sites across Australia, and these sites cover the urban, rural, and remote regions of the country. And to recruit these participants, 18,145 homes were knocked. So we received a pretty good response rate of about 74%. So it was a very hard-working field team that we had out there. And participants were also recruited through other avenues like flyers that were distributed by community groups. So in the end, 4,519 participants were recruited. Of those, 3,573 completed the hearing survey. Of those who did the ear health component, 13% were Indigenous adults and 87% were non-Indigenous adults aged 50 and over. So if we look at bilateral hearing loss, so this is hearing loss that occurs in both ears, around 40% of Australian adults aged 50 and over had some form of bilateral hearing impairment. The majority of the hearing loss that we detected in this population was mild hearing loss, but there was about around 1 in 7 who had moderate or worse hearing loss, which is classified as disabling hearing loss. If we look at the prevalence rates between Indigenous and non-Indigenous adults, you can see it's quite similar. However, when we look at it by age group, the prevalence of any hearing loss and the prevalence of moderate or worse hearing loss is significantly higher in our Indigenous adults compared to non-Indigenous adults for every age group except for those aged 80 and over. This suggests to us that hearing loss potentially develops much earlier in Indigenous populations and could be more severe. So we also asked our participants who had a hearing loss if they've reached out to a healthcare professional. And so over 2/3 said yes, that they had. And what we found is, though, that Indigenous participants were slightly less likely to talk to a healthcare professional about any sort of hearing problems compared to non-Indigenous adults. Nearly 70% of our participants with moderate or worse bilateral hearing loss reported the use of a hearing aid. So there's still about 1 in 3 who have potentially disabling hearing loss that are not accessing any hearing intervention or using a hearing device. And this is concerning because it does suggest that there is an unmet need for hearing services in the Australian adult population. So now going on to the myths. The first myth I wanted to highlight is that hearing loss is a natural part of aging. So there is this misconception that people think hearing loss should be accepted as a normal part of getting older. But the research shows that hearing loss affects people of all ages and it shouldn't be dismissed as a trivial problem. The second myth is that hearing health is an isolated issue. There is increasing evidence now to demonstrate that hearing health is integral to overall health and well-being. So hearing better helps you live better, essentially. So when we're talking about bridging gaps and dispelling myths, awareness and education are absolutely key to driving timely detection and management of hearing loss in adults. And secondly, multifaceted research which demonstrates the health, psychosocial and economic impacts of hearing loss are also critical in order to drive improvements in hearing services and also to inform hearing health policies. And finally, reframing the messaging, conversations and perspectives in light of this evolving evidence will promote healthier and more inclusive communities. But there is this challenge of low levels of awareness, and this was shown in a large US survey of patients, and only 9% of these patients were able to correctly identify what constitutes normal or average range for hearing. And however, 93% of these same patients were able to identify what normal vision was, 85% were able to identify what normal blood pressure was, and over half were able to identify what normal cholesterol levels were. So there is this stark difference in levels of awareness between hearing loss and those other chronic conditions. But there are now public health campaigns that aim to raise awareness. So probably the best known one is the US Know Your Hearing Number. So if you Google Know Your Hearing Number, it'll take you to a website and you can download the Hearing Number app for free. and it allows you to test your hearing, and it will give you a hearing number, one for your right ear and one for your left ear. And the hearing number essentially tells you the softest speech sound that you can hear. If your hearing number is between -10 to 19 dB, you're likely to have little to no trouble hearing in noisy places. Of course, your hearing number is going to change over time and with age. So I'm in my mid-40s, and my hearing number in one ear is about 10 and 11 in the other. So it's slightly above the average range for that age group, but still within the normal range. But I'll certainly be tracking it over time. So in addition to understanding metrics around hearing loss, or numbers around hearing loss, it is important to know some of the common signs. So some of these common signs are shown on this slide. So it's things like problems following a conversation in a noisy restaurant or a noisy cafe, difficulties on the telephone, misunderstanding people, and turning up the volume on the TV or radio. And it's important to be aware of some of these signs, because these could serve as the prompts to getting people to doing something about their hearing. So I want to go on to that first myth, which is that hearing loss is a natural part of aging. Again, I've taken this figure directly from the WHO World Report on Hearing, because it summarizes quite nicely the causative and protective factors that influence an individual's hearing capacity across their life course. And unfortunately, we can't do much about getting older. However, there are plenty of other ways that we can protect our hearing. So for example, using hearing protection when we're in a noisy work environment or attending a noisy concert, having a healthy lifestyle, which includes good nutrition, and avoiding smoking, are all effective strategies that we can all implement to maintain our hearing. So our group, not so long ago, comprehensively reviewed the published literature that was out there in terms of risk factors for adult-onset hearing loss. And the findings of this work really helps to dispel the myth that hearing loss is inevitable as we get older, because the key findings were that it really highlighted the importance of some of the other determinants of hearing loss, such as ototoxic factors. So this is chemotherapy drugs and certain antibiotics, environmental and lifestyle factors such as exposure to workplace noise. We also found, interestingly, emerging evidence for COVID-19 to play a role in the development of hearing loss in adults. So we can potentially target some of these risk factors in order to provide more effective preventive and treatment strategies. That second myth is hearing health is an isolated issue. And so, Your Excellency, you did talk about this quote from Helen Keller, but I'm just going to reiterate it again, which is, blindness separates us from things, but deafness separates us from people. And I think this quote sums up really nicely why losing hearing is not a trivial issue and how important this sense really is. Because we as humans are social creatures, and when communication becomes challenging, as it is for people with hearing loss, they minimize their interactions and they withdraw, or increasingly withdraw, from social situations. And this has been shown in the research. So there are studies that have shown that unaddressed or untreated hearing loss is associated with a greater risk of social isolation. So for every 10 decibel drop in hearing sensitivity, the odds of social isolation increases by over half in 60 to 69-year-olds. And this is bad news, because we also know from research that social isolation has the same risk of mortality as smoking up to 15 cigarettes per day. And also, we're currently in the midst of a global loneliness epidemic. So potentially targeting or addressing hearing loss could be an effective strategy in terms of minimizing the impacts of social isolation. I do also want to highlight and talk about some of the key findings from the Blue Mountains Eye and Hearing Study. This is a landmark sensory loss study that I was fortunate enough to be involved in, and I started on this project when I was a junior postdoc many, many years ago. And what the data from this Blue Mountain study showed was that hearing loss leads to a multitude of negative health and social impacts, and it certainly is not a trivial issue. So firstly, we were able to show through the Blue Mountains cohort some of the direct impacts of hearing loss, which included reduced speech understanding and communication difficulties, reduced music enjoyment, and in terms of indirect impacts, we found that participants who had hearing loss were more likely to experience poorer quality of life. They were more likely to experience depressive symptoms, and hearing loss was associated with a greater risk of experiencing difficulties in carrying out everyday activities of daily living, such as doing the shopping or using the telephone. It was also associated with a greater risk of falls in the long term. And in terms of social outcome measures, we found that the presence of a hearing loss was associated with earlier retirement and earlier workplace separation. And it was also associated with reduced functional independence. So people with hearing loss were more likely to use these formal or community supports, like getting a community nurse to visit them or getting Meals on Wheels services. And some compelling data was that we found that the presence of hearing loss was associated with the greater risk of mortality in the longer term. And more recently, we found that our participants who had a hearing loss were less likely to reach old age disease-free, fully functional, and in good mental and physical health compared to the normal hearing counterparts. So they were essentially less likely to age successfully. And probably one of the most compelling reasons to do something about your hearing is the link with dementia. So the Lancet Commission published a report last year on dementia risk factors, and what they found was that hearing loss in midlife was among the top 2 modifiable risk factors for a dementia diagnosis in later life. So the risk linked to hearing loss in midlife was actually greater than the risk linked to, for example, lower education in early life, or even the risk linked to depression, traumatic brain injury, and social isolation in later life. So this is really compelling evidence to do something about your hearing. So why would hearing loss and dementia be related or linked? There are several pathways that have been put forward. So firstly, untreated hearing loss does place that additional cognitive load on the brain, and that means that it struggles to process auditory information. So over time, there is this fatigue, there's this cognitive strain, which could contribute to the development of dementia. The second pathway that's been hypothesized is via social isolation. So as I showed earlier, there is this link between hearing loss and loneliness and social isolation. And we also know from research that lack of social engagement can lead to a decline in cognitive functioning. Finally, one of the other pathways is that some studies suggest that hearing loss could actually lead to structural changes in the brain, such as atrophy in those regions that are responsible for memory and cognition. Luckily, it's not all bad news. I wanted to sort of highlight some key findings from this large US clinical trial known as the ACHIEVE trial. It is a busy slide, so I will try and summarize as best as possible. So what this trial found was that those older adults who received a hearing intervention, which was essentially hearing aids as well as audiological counseling, had about a 48% reduction in risk of experiencing cognitive decline compared to the control group that did not receive this intervention. And it was specifically found in those adults that already had a greater risk of dementia due to the fact that they had these cardiovascular disease risk factors. But nevertheless, it is really encouraging and promising to see that if you do something about your hearing loss, if there's timely intervention, you can actually maintain optimal cognition in the longer term. So myth number 3 that I wanted to talk about is that communication difficulty is a personal challenge. What the research shows is that communication difficulties at an individual level have those ripple effects. So there are those broader societal and public health impacts from hearing loss. Myth number 4 is stigmatization of hearing devices. Again, there are studies to show that hearing devices are in fact valuable tools for improving communication and quality of life and allowing people with hearing loss to live their best lives. So going on to that, communication difficulty is a personal challenge. I know that Your Excellency, you did talk about the Access Economics report. There's been a more updated report since then. So this is findings through Deloitte Access Economics. And what they found is that the total financial cost of hearing loss in Australia in 2019 to 2020 was estimated at around 20 billion. And this includes health system costs of about 1 billion. The largest component of health system costs was the Hearing Services Program cost, which is provided by the Australian government. So the Hearing Services Program provides free hearing services and free hearing aids to people who are eligible, for example, pensioners and veterans. The report also found productivity losses of around 16.2 billion. Most of this was due to reduced employment of people with hearing loss. So ABS data actually shows that men and women who have hearing loss are on average, or had on average, a lower likelihood of being employed compared to their hearing colleagues. And these costs related to hearing loss are only going to be increasing exponentially with the aging demographics of the Australian population. So there is this huge economic and public health impact that is linked to hearing loss. So stigmatization of hearing devices is a big challenge. Again, I've taken this figure directly from the WHO World Report on Hearing, and this report indicates that timely and appropriate care ensures people with hearing loss can achieve their full potential. So when we talk about hearing interventions, there's hearing aids, which is recommended for people who have mild to moderate hearing loss, and cochlear implants recommended for people who have severe to profound hearing loss. There's also hearing assistive technologies, including hearing loops, Bluetooth streaming, and captioning services, but also rehabilitative therapy and audiological counseling. So there is a whole range of hearing interventions that are available that can ensure that people with hearing loss maintain optimal quality of life. However, people still picture hearing aids, as it was many years ago, large and obvious, making those embarrassing whistling and beeping sounds, and ineffective at filtering out background noise. But today's models are actually more quiet, discreet, and effective. And if you sprinkle in a bit of Apple's magic on these devices, we hope to minimize the stigma around wearing them. So I really do like this media article title, which is, "Can Apple Help Make Hearing Aids Cool?" So recently Apple released their AirPods Pro. This functions as hearing aids for individuals who have mild to moderate hearing loss. They utilize a hearing aid feature which boosts specific frequencies to improve clarity. So the hope is that the association with Apple is actually going to make a difference in terms of getting people through the door in the first place and minimizing the stigma around hearing loss and minimizing the stigma around wearing a hearing device. The other technology, which is also quite cool, and it's a recent technology, is Auracast. So this is the next generation of wireless technology that will make hearing in public places and shared audio experiences easier than ever. So with Auracast, a public audio source can broadcast sound directly to a number of compatible devices, including hearing aids. So Auracast is currently available in the Sydney Opera House and in sports stadiums. So this is all about ensuring that we are creating an inclusive community. But the one that I'm really excited about are these eyeglass hearing aids. These have microphones that are built into both the front of the frame and the temples. This system can effectively isolate speech coming from the direction that you're facing while filtering out surrounding noise. So they're really designed, again, for people who have mild to moderate hearing loss. So I believe these eyeglass hearing aids might be available in Europe this year, potentially US, and hopefully it won't be long before they hit the Australian market. I do want to end the presentation by highlighting some of the public health approaches that our group is leading or involved in. So the first project I wanted to highlight was embedding routine hearing health checks within existing Meals on Wheels services. It's called the Sound Bites program, and we're also embedding hearing health checks within existing Marathon health services. So this project is underpinned by a community-delivered model of care, which has 3 pillars. The first pillar is task shifting to trained non-specialist providers. So in the case of this project, we are training community health workers and nurses from Marathon Health to do the hearing screening, and we're also training our volunteers from Meals on Wheels to help with the hearing health check. And task shifting has been identified by the WHO as absolutely critical to ensuring equitable access to hearing services. The second pillar is the use of mobile health or mHealth technologies. So in the subsequent slides, I will talk a little bit more about those technologies that we're using. And finally, as with any sort of model of care, it needs to be seamlessly integrated into existing structures, community structures and services. So if we talk about the services provided by these organisations, Meals on Wheels is a non-for-profit registered charity. It actually has greater reach than Telstra in New South Wales. They have 14, someone actually said that's not very hard to do, but so they have 14,000 volunteers that deliver over 4.5 million meals per year to over 22,000 clients in New South Wales. And these clients do tend to be vulnerable, older, isolated adults. And these meals are distributed by 140 local branches or food services. They are governed by the slogan that it's more than just a meal. So these volunteers deliver the meals, they ensure there's a social interaction with these clients, and there's a friendly check of the client's well-being, as within this friendly check that we're embedding routine hearing health screening. We're also working with Marathon Health. They're the largest non-for-profit employer of allied health professionals in regional New South Wales. They deliver face-to-face services to over half of New South Wales and virtually Australia-wide. So they deliver programs like chronic disease education and management programs, and also programs around healthcare system navigation. So it's within these programs that we'd like to embed routine hearing health screening. In terms of the devices, one of the devices that we're using is this ArcLight device. It's developed by the Global Health team at the University of St Andrews, so we work really closely with them. It's a pocket ophthalmoscope and otoscope, which helps to identify some of the common causes of vision and hearing loss. So with the otoscope, we can look at the eardrum and ear canal. It's easy to use, portable, low cost, and solar powered. We're also working with Sound Scouts. They're an Australian company that have developed this tablet-based app. It's a low-cost, easily administered, quick hearing test. And it's really like a mobile game, and it's very easy for people to go through and get their hearing tested. So currently we are piloting this program with Meals on Wheels services in the Sydney metro region, and with Marathon Health we're piloting it in the Murrumbidgee region, and trying to ensure that we have hearing services provided in those regional and remote parts of New South Wales. The second project I wanted to highlight is the HIDI project. It stands for Hearing Impairment Data Infrastructure Study. So with this, we created firstly a data warehouse. So we linked large general practice data sets in Victoria and New South Wales with a large audiology clinic data set, which was provided by Hearing Australia. So Hearing Australia is the largest provider of government-funded hearing services. By creating this data warehouse, we hope to provide an interdisciplinary perspective to hearing health, which was currently lacking at that time, and to have a comprehensive a picture of the patient journey from the GP clinic all the way to the audiology clinic. So analysis of the data warehouse actually showed, unfortunately, that GPs had very minimal involvement in that whole patient journey. So while patients who ended up with a hearing loss diagnosis were fitted, the majority were fitted with the hearing device, about 68%, only a fraction actually had GP involvement quite early on in their journey. So only 3.3% of patients had a hearing-related GP visit before diagnosis, and of those who had visited their GP about a hearing problem, only 0.8% received a GP-led hearing intervention. So, for example, this is a GP doing a hearing test, so doing pure tone audiometry, and only 42% of these patients actually ended up being referred by their GP on to an audiologist for further hearing evaluation. So analysis of this data actually highlighted to us that there is an urgent need to better integrate hearing help into the general practice setting, and that's exactly what we're trying to do right now. So we have developed a clinical decision support tool for hearing loss, and we've embedded this into something called Future Health Today, which is developed by the Division of General Practice at the University of Melbourne. And Future Health Today is an electronic quality improvement tool that's used by GPs to manage chronic diseases. And so we're embedding a decision support tool on hearing loss within this platform. And as we speak, hopefully this week, we will have started the pilot study. So 35 clinics, GP clinics across New South Wales, Victoria and Queensland. We're going to pilot the tool and determine the feasibility and acceptability of this tool for GPs, and then further refine it before we widely implement it across Australia. I also wanted to just quickly touch on some of the global and local efforts that we're involved in to develop best practice guidelines to ensure standard of care for adults with hearing loss. So a global cochlear implant task force was formed back in 2021. This included 52 members representing more than 20 countries, including a few of us here from Australia. And this task force developed the very first evidence-based living guidelines for cochlear implantation in adults. And this was so that we could optimize the standard of care for all adults who are eligible for a cochlear implant, and to have those clear referral pathways and clear guidance. The final version of these guidelines were published last year, and it was always intended that every country adapt and adopt these guidelines. So for ANZ, Australia and New Zealand, this process is very much underway. It's driven by the ANZ Hearing Health Collaborative, which I co-chair along with Professors Catherine McMahon, Payal Mukherjee, and Dr. Jamie Lee. And we have 3 working groups, and the collaborative itself has 70 volunteer members who broadly represent the hearing health sector and beyond. And we just finalized the adoption of these guidelines to the ANZ context. We're just seeking that final endorsement from the collaborative members. We're almost there in terms of consensus, and hopefully we will be launching the guidelines end of next month. So it was definitely a labor of love. So I just wanted to highlight a new partnership between Macquarie University Hearing and the George Institute at UNSW, which aims to enhance the reach and relevance of hearing research and hearing studies. So the George Institute has developed something called the Join Us Research Register. It's a national register that connects the Australian public with health research. And what we hope with this new partnership, collaboration, and with this national platform is that we can enhance the participation of Australians in hearing-related research. And it's really this enhanced participation which we hope will drive innovation, drive policy development, and also essentially improve outcomes for all Australians with the hearing loss. So I would like to acknowledge my fantastic team. I don't do any of this research in isolation. Dr. Diana Tang, my ECR, who's also part of my team, is here today. And if you want to know more about our research, you can visit the website or email me. Thank you.
I'm Slade. I have the great honour of being the current president of the Royal Society of New South Wales, and I'm here to take some questions and answers for Bamini. I must say, as Her Excellency said, this is a rather sobering talk for our demographic. I'm delighted to see some young faces, including, of course, your daughter, to make us feel a bit less as though this is but it's not an easy topic. So please, any questions?
Can you speak up? Thank you. First, thank you very much for a very nice presentation. In making the link between hearing loss and dementia, you postulated that one of the possible mechanisms is that continual failure to interpret what is being, for instance, said by someone in a crowded space produces a cognitive load that eventually amounts to a chronic cognitive strain. Now, this seems contrary to the advice that one normally receives in respect of avoidance of dementia, which is that basically one needs to continue as far as possible to engage in activities that involve nimble brain processes, whatever it be, playing a musical instrument or social engagement, whatever. Is there actual hard scientific evidence for this concept of overload cognitive strain that you put up? Thank you.
Yeah, that's a great question. So there is ongoing studies at the moment that are looking at how hearing loss and dementia are linked. So these are just, at the moment, potential hypothesized pathways. And with hearing loss, there is this reduced input that is going in because there is a lack of information that is coming through. And so the brain is working harder. And so this fatigue actually leads to that strain, which could potentially have a negative impact on cognition. But in terms of like hard scientific evidence, there's still ongoing research, and there's nothing that has been concretely shown to say this is exactly how hearing loss leads to dementia risk. So, for example, in our group, I can give you a project that is about to initiate, where we're looking at hearing device users, and we will look at sleep, because that's another potential pathway, so hearing loss via sleep. And we all know if we don't sleep well, this can lead to negative impacts on cognition, and there is a link between hearing loss and sleep as well. So we are tracking the sleep of the sleep patterns of these participants. We will be doing EEG and MRIs just to see what the structural changes are over time. So it's studies like this that hopefully will provide the evidence, but at the moment there is no sort of established causal pathway between hearing loss and dementia. It is still watch the space.
One little bit of better news.
Yeah.
Yes, at the back there, Robert Clancy. Oh, Robert. No, sorry, the other Robert has got the microphone, and then to Robert Clancy next.
I'll just stand so you can hear me. May I start by congratulating you? I could hear every word and understand. I can also testify that not hearing, being able to make out what my daughters are saying, particularly my youngest 23-year-old with a master's degree who speaks like a submachine gun, is very fatiguing in both her mother and myself. So I can make a point of that. Now, my own experience, and forgive me here, I'll get to the actual question in half a tick, is I'm a cranky old fella, and my daughters know me as that, and I wish that wasn't the case. I've had hearing checks 20 years ago, and yes, it was not the year I thought it was. And I don't know if it was an AC/DC concert in 1980 or it was the sound of steam-driven anvils driving piles down at Darling Harbour. One of the two, or both. Now, I find I hear volume. I cannot necessarily distinguish the language, and I constantly make hand gestures to my children, slow down and open up your mouth, are the two biggies. Now, when I had my hearing checked all those years ago, the cheapest hearing aid was $15,000, and I'm going, what a self-indulgence. No, I'm not going to waste that sort of money. And now I'm being, because I hit a profile, I guess, inundated with ads for $150 hearing buds. Are they of any use, is the ultimate question.
Okay. I'm sure that you could organise a consultation out at Macquarie.
Yeah, I mean, those earbuds are really for people with mild to moderate hearing loss. The first thing I would say to you or recommend is get your hearing tested to understand what level of hearing impairment you might have or might not have. And based on that, your audiologist would be able to recommend the most appropriate device. Hearing aids now range from about 1,000 to 6,000. Yes, you've got those top-end ones, which are about 10,000. And if there is the hearing services program, so people can access those hearing aids for free and hearing services for free if they're a pensioner, for example. But those earbuds are definitely more for people that have mild to moderate loss and may not be so appropriate or suitable for people who have...
Right. That's very careful and gentle and diagnosis, Robert.
Bamini, that was a very important talk, and as someone who does need hearing aids, although I don't wear them very often, I value that. When you put that, I think it might be the first or second slide up, with incidents of impaired hearing, it seemed that younger children had proportionately higher impaired hearing than a lot of older people. Now, that would suggest either it's transient or it's a surrogate parameter for early death, in that it's an indicator of other issues. Would that in fact be true? Or just for a certain subpopulations?
So you're talking about the national survey data? Yeah. So we didn't look at children. It was all adults aged 50 and over.
They're all... I thought you had one there with younger.
No. It was it was my mistake. It's probably not very clear on the axis. So
does that mean then for the people who were younger in that particular group that it was an index of mortality or death risk, or was it transient?
No, it wasn't death risk. It was prevalence. It was just showing the prevalence.
But it was
rates.
higher in the younger ones than the older ones.
So up to age 80, it was the Indigenous adults had a higher prevalence of hearing loss compared to non-Indigenous adults, and that's from age 50 onwards. So it's not children, it's actually...
Why is that so? Is that an index that those people will die earlier then?
No, not necessarily. Mortality risk is influenced by many other factors, not just hearing loss. So what that means is there are certain risk factors in the Indigenous population that predisposes them to having a hearing impairment. So, for example, they do have a history of middle ear infections, and also, for example, smoking, higher levels of smoking, higher levels of diabetes. Diabetes and smoking are significant risk factors for hearing loss, and we actually found that these sort of risk factors were more prevalent in our Indigenous population versus non-Indigenous population, which probably explains why the prevalence rates are higher in this group compared to non-Indigenous.
We've got one more question, just here.
Oh, you take. Oh, is that okay? My question was just in regards to adults who don't fit within that age range. So up until the age of 26, people in Australia can get hearing aids subsidised by the government for free. They then are no longer eligible for that service once they turn 26 until they then, quite a few decades down the road again, when they become, when they're a pensioner or something like that. I suppose my question is, how would you be encouraging adults who are between that age of 26 and then pensioner age, when they're having to pay about $8,000 for their hearing aids, to actually get them when they're sitting there going, just about that cost aspect again, that is a lot of money that they're paying every potentially 5 or 10 years for an ongoing hearing loss, and they're not eligible for any funding under the NDIS, and you have to have the highest level of health insurance, and that health insurance actually doesn't cover your hearing aids either. It covers a couple of $100s. So what is the initiative then for those younger adults who will grow into those older adults to get those devices? Thank you.
It is a huge challenge, that gap in the hearing services program. And it's a hard one. I really don't have the answer to that, and I don't, from our research, there's nothing that we could do to get those younger adults through and getting them to do something about their hearing if they've got a problem. What we know is there was some recent analysis done, I don't know if it was done through the hearing care industry, but it actually showed that if the government did expand that age group, it actually would end up being cost effective and in the long term be a huge cost saving exercise, because it would prevent those other flow on impacts of unaddressed hearing loss. So including, as was shown, reduced workplace productivity, lower levels of employment, and I know this report has been presented to the government, but as of yet, nothing has been done in terms of expanding that age group. And so it's an ongoing challenge. It's really, if we're looking at it from a public health perspective, it's things like awareness and education, hoping that would be a driving factor for people to do something. And the group that doesn't qualify for the free hearing services program, but it's a tough one. I mean, you're right. The health insurance.
No, I've got the nod from the Colonel over there, so we must. I must stand now, and perhaps I'll stand at the lectern to thank you. So thank you very much. We've no more questions. I have a very difficult task tonight. I've got to thank Bamini, but I also particularly want to thank the Governor, who started these programs, Ideas at the House. It was her idea. She came to the Royal Society of New South Wales to create something which I think has been quite extraordinary. As she said, it's the 14th. Lindsay takes all of the content, and you can see all 14 of them on our YouTube channel for the Royal Society. They've gone from Jason Sharple's On Fires to John Bell to Thomas Keneally. In fact, I think that's the first one I was involved in. I was, I suppose, doing the thanks at the time. And it's been an extraordinary adventure and an idea. And I think we at the Royal Society are really grateful to the Governor for having this idea, which is one which is very true to our heart, which is that we are trying to bring together reasoned, informed, evidenced, and imaginative research with people from across a range of disciplines and from outside academia, and to deal with it in a reasoned and civil way. And I don't think we could have had any better example of that than the Governor's introductions to each of these ideas at the House, which show an extraordinary range, a real Renaissance woman, from hearing to fire to Shakespeare. And I think perhaps that's really what we need to be aiming to do with the Society. So that's my first part of the thanks. And I started there because it was the Governor who requested a session on hearing. And I must say, I did say to one of our younger fellows, oh, we've got this fantastic session on hearing. And he said, hearing? So there is still quite a feeling about it. And luckily, I had met Bamini with Wendy as well. We were trying to set up a centre for regional and remote, regional health centre at Charles Sturt University, regional medical research. Robert Clancy was also involved. And she was suggested to me as a person who understood and was beginning to do the research, at the research she's reported today on hearing and seeing health. There are issues that I've cared about a lot. My own father, before Fred Hollows, had started trachoma work in northern South Australia, where he was beginning to try and do something about Aboriginal eye health. But in many ways, the hearing loss is a far more insidious problem, not just for us who are old, but for the young. I did some work when I was teaching reasoning to young children with people at the Rhode Island School of the Deaf. The cost or the impact, as Helen Keller said, but of congenital hearing loss on reasoning skills is quite extraordinary. And the effort to try and get around that is really hard. So I think these are really important issues. Bamini, the other thing that you've done for us today, which is quite marvellous, is shown how you can work beyond the university, creating partnerships. And if Michael will let me, could I have one more thing? One more thing. When I was reading, thinking about this topic, I thought of Elisabeth Noel Neumann, who was a German academic who had studied in the States, went back to Germany and was there during the war. And after the war, she started a concept of the spiral of silence, the way that when issues are not discussed in a community or there's a particular view which is the strong one, that people with contrary views silence themselves. And I thought, what we've got here is, Bamini's got a sort of a double helix of a spiral of silence. We've got the society, which doesn't let us hear about, where deafness we don't talk about. As you say, it's stigmatised. And at the same time, this downward spiral of hearing loss, which we need to intervene in. So I think it's been a very, very interesting talk for us all. And as I say, it is a bit challenging for us all as well. I notice that it's the women who are doing the research here, and you wonder why. But there you are.